remember you about certain terms and its definition. Premature, a live infant delivered before 37 weeks from the last day of the last menstrual period. Low birth weight, of course, less than the ideal birth weight, that's about 2.5 kg or less. Of course, may be due to prematurity or to other causes that cause retardation of the newborn side uterus. So low birth weight may be premature or not premature. Prematurity and intrauterine growth retardation, of course, associated with increased neonatal morbidity and mortality, because prematurity and growth retardation also followed unfavorable certain conditions. So mortality and morbidity increase with such abnormal conditions. Very low birth weights, of course, weight less than 1.5 kg, and of course, most of these new delivered infants are premature, but not all very low birth weight premature. As we say, prematurity, it means less than 37 weeks, not the weight. Prematurity, of course, a result of certain conditions. These conditions comes from different causes. First, the cause may be related to the fetus itself. For example, multiple gestations, twins, or fetal distress to other causes. Placenta previa, insertion of the placenta in not ideal place, or placental dysfunction. Uterine, bicornate uterus, it means there is no extra space for neonate to be increased in its gestational or even weight. Maternal disease, heart disease, diabetes mellitus, renal disease, or different maternal functions. Other possible causes: early premature of the membrane, trauma, or polyhydramnios. The premature infant may show these signs soon after birth. So, the premature may present in one or of these clinical presentations. Trouble breathing, the most important complications of prematurity, immaturity of the lung. B, low birth weight, of course, not all the time. Low body fat, inability to maintain a constant body temperature, of course, due to low body fat. Less activity than normal, movement and coordination problems, of course, more in the premature baby. As we say, prematurity is unwanted neonatal conditions because these conditions not free of complications. So, possible complication of prematurity as follows: brain hemorrhage, so common and may result in bad sequelae in immediate or on the long term. Pulmonary hemorrhage, hypoglycemia, because the storage of the newborn less than term infant. Infections due to defect in the immunity, of course, anemia in most of cases, patent ductus arteriosus, of course, in this type that follow prematurity, the ductus most likely functional, not structural, and may close with time. Respiratory distress syndrome, due to the immaturity of the lung and surfactant deficiency, considered important complication of the prematurity. So, in every premature labor, you suspect one of these or even more. Long-term, look for premature infants. Besides acute clinical problems that we mentioned, these premature may suffer from long-term complications like hearing and speech problems, vision loss or blindness, learning disabilities, physical disabilities, delayed growth, and poor coordinations. So when the premature delivered and pass the acute complication of prematurity, these premature should follow later on by assess such conditions to interfere immediately. So premature baby generally complain from a lot of cognitive and physical abnormalities. So intellectual function should be assessed in different periods to discover and treat early. As we talk about the prematurity, we talk now about post-maturity, opposite to that of premature, post-term infants. We said previously, post-term infants are those born after 24 weeks completed, of course, regardless the birth weight. Mature or premature or post-mature not depend on the weight, depend on the weeks of gestation. So post-term, of course, delivered after 42 weeks. Clinical features may involve skin desquamation, long nail, abundant hair, pale skin, a large face, and loose skin, meconium stained nails, and umbilical cord. This is important. The last sign is important because it indicates certain fetal distress. Presence of meconium in the amniotic fluid indicate all the time fetal distress. Complications of post-maturity include perinatal depression, meconium aspiration syndrome, persistent pulmonary hypertension, hypoglycemia, hypocalcemia, and polycythemia. So, post-mature, in spite of its post-mature, of course, not free of complication like that of premature. So, ideal birth, it should be after 37 and before 32 weeks. We have another term regarding a newborn that we call large for gestational age. Large for gestational age. Of course, means infant with birth weight more than 19th percentile for gestational age. And this is called large for gestational age. So, if we expect the birth weight of a newborn with 30 weeks about 2 kg, here in large for gestation we can find it as a more than 3 kg. So the weight here more than the expected weight for its gestation. Of course, this may follow different causes. So, may cause a lot of complications. Generally, neonatal mortality rate decreases with an increasing birth weight until approximately 4 kg. All the time, we're seeking for optimal birth weight, but birth weight that start to be more than 4 kg, it's unfavorable condition. Patients. Large for gestational age may deliver to a mother that complaining from maternal diabetes, or obesity, that we can say is familial. Infants have a higher incidence of birth trauma because these infants are macrosomic, large birth weight. So brachial plexus, fractured clavicle, kebal hematoma, or other complications that result from such abnormal weight. As we say, other complications like hypoglycemia, polycythemia, and increased congenital anomalies, of course, may follow such group of neonate or newborn. Other term that we should know about: intrauterine growth retardation and small for gestational age. Intrauterine growth retardation represents a deviation from the expected growth pattern. Usually in utero, we have a direction for growth and development. So, intrauterine growth retardation, retarded growth inside utero to a certain unfavorable conditions. Other term, small for gestational age, describe infant whose birth weight is statistically less than 10th percentile or 2 standard deviation below the mean for birth weight in comparison for gestational age. So, at birth, we expect the ideal birth of newborn about 3 and less more 3 kg. In small for stage, we can find about 2 or even less in weight, kg in weight. So small for age describe infant who is born with not ideal birth weight for his age. So the birth weight less than normal in spite of this newborn with complete gestational age. Of course, intrauterine growth retardation and small for gestational age may follow a certain problems. Of course, may be related to mother, fetus self, or other problems. Maternal causes, genetic short stature, factions, especially congenital factions, younger age group, smoking, poor nutrition, black race, chronic disease like diabetes mellitus, causes related to the fetal, congenital factions, defect in the metabolism, multiple gestations, or chromosomal abnormalities like Down syndrome. Maternal medications, anti-metabolites, lead, mercury, narcotics, steroid, or even warfarin. Placental and uterine, abruption of placenta, or abnormal implantations. All of these can be considered logical cause of growth retardation or small for gestational age. Here, to take more ideas about small for gestational age. At birth, infants who are mildly to moderately small for gestational age appear to be smaller than normal with decreasing subcutaneous fats. More severely affected may present with a wasted appearance with asymmetrical finding, including a larger head for size of the body. So the most important in this newborn central nervous system is spurred. This is so important for the future growth. Wide anterior fontanelles, small abdomen, thin arms and legs, decreased subcutaneous fat, dry skin, or even meconium-stained amniotic fluid. or staining on the umbilical cord. So all of these problems can happen with such new or small for gestational age. Physical examination of small for gestational age should detail the presence of dysmorphic features like abnormal extremities and hepatosplenomegaly, jaundice, skin rash, and cataract. All of these suggest the presence of congenital infection or metabolic defect. So most important for you to assess thoroughly every newborn, especially term infant with low birth weight, and accept such clinical features that indicate the congenital infection or metabolic defect. Of course, all of these, you should screen these infants for such problems. Infant with severe intrauterine growth retardation or small for gestational may have a problem at birth include respiratory acidosis, metabolic acidosis, asphyxia, hypotension, hypoglycemia, polycythemia, meconium aspiration syndrome. So, generally speaking, every newborn that deviated from term infants, premature or post-mature, or reduced in the weight, certainly may suffer from a lot of complications. So our goal in pregnancy to make the pregnancy progress to the term labor. Management of growth retardation or small for gestational age is usually introduced to different groups of these infants according to their symptoms, and of course our treatment all the time supportive. The diagnosis evaluation at birth should be direct to the cause if possible. The mortality rates about 5 to 20 times those of infants who are appropriate for gestational age. Postnatal growth and development depend on part on the etiology, the postnatal nutrition intake, and the social environment. So important to seek for the cause, to interfere and correct the pathology. Generally speaking, infants who are intrauterine growth retardation and small for gestational age secondary to the congenital infections or chromosomal abnormalities or concerted symptom remain small throughout life, because newborn that develop in certain syndromes like trisomy 21, Down syndrome, of course, these infants start to be less than usual even in adulthood, because their condition are permanent, not corrected or beyond any correction. Down syndrome of course, beyond treatment, unless few signs symptoms that may be acquired later on. Infant who are growth inhibited late in gestation because of uterine constraint, placental insufficiency, or poor nutrition have a catch-up growth and approach their inherited growth and development potential under optimal environmental conditions. So, if there is no congenital infection or chromosomal abnormalities, these intrauterine growth retardation or small for gestation, infant can grow normally if you interfere to correct acquired intrauterine abnormalities. Here we talk about different issues regarding a newborn. Multiple gestation, multiple gestations, roughly we can say twins. What are the incidents? Of course, a high incidence in our societies. So approximately 1 to something % of all live births are the result of twin gestation. In fact, the true incidence of twin gestation is slightly higher. Multiple gestations, of course, may be monozygotic or dizygotic. Monozygotic, that result from one ova that fertilize later on, and monozygotic, of course, and dizygotic, of course, result from more than one ova that fertilize later on. So we have two types of multiple gestations. Monozygotic twins, of course, consider less than half of multiple gestations, in a percent around 4 in 1,000 live birth. So it consists about 40% of all twins that who born alive. So generally speaking, dizygotic twins more common than monozygotic twins. Etiology of such phenomenon. Monozygotic twin may be viewed as a teratogenic event because it occurs more frequently with increasing maternal age. So here, the maternal age plays an important factor. Of course, this type of twinning associated with more congenital abnormalities and can be caused by teratogene. A problem of asymmetry in the developing embryo may result in conjoined twins. So here, the complication, of course, more than dizygotic or even more than delivering of a single newborn. The incidence of monozygotic twin is unaffected by race or by familial factors. So, monozygotic twins increase with increasing maternal age, increase the associated complications, the incidence of it's not affected by race or by familial factors. Dizygotic twinning is caused by double ovulation, which may be related to the elevated gonadotropin. Twin not of the same sex are dizygotic, while monozygotic twin all the time the same sex, either male or female. But in dizygotic twin may born with the same or not the same sex. Zygote and recorded at birth through careful examination of the placenta. Of course, any birth with more than one placenta considered dizygotic, while monozygotic twin, of course, with a single placenta. Possible causes of twinning due to treatment of infertility with certain drugs that increase fertilization, and so the ovaries start to be product more than one ovum. So here you can make a comparison between the monozygotic twin and dizygotic twin from point of incidence, complications, number of placenta, and gender of the newborn. Of course, this condition not free of complications. Death may be occurred because of cord accident and twin-to-twin transfusion, because these twins connected to each other. Of course, this can lead to the death of one of the fetus or even both. So if when fetus die, thromboplastin release and subsequent DIC in the second one. Growth disturbance are the role. Intrauterine growth retardation, there is a decreased potential for growth in twin fetus compared to the single fetus, probably owing to the limitation of placental area for nutrient transfer. Important conditions that we call twin-to-twin transfusion result in large polycythemic twin and small anemic one, So here, each of these twins connected to each other. So the first twin considered to be a recipient of the blood, and the second one, the first one constitutes the donor of the blood, and the second one constitutes to be a recipient of the blood. So in spite of the first twin receive the blood, later on this start to be anemic, while the second and the recipient, second twin that receive blood from the donor start to be polycythemic. So we have the donor anemic while the recipient polycythemic. Of course, this phenomena not free from complications. The incidence of congenital malformations, of course, doubled in case of twin. Spontaneous abortion also increased. Preterm delivery is the most common complication of the multiple gestation. It occurs in about half of twin pregnancies. The incidence is even higher in triplet and quadruplet pregnancy. So, prematurity increase with increasing number of twinning, and even the complication increase with increasing number of twinning.
دكتور ضربي مقطوع.
What? Okay, what? Growth retardation, perinatal asphyxia, especially of the second twin, because the placenta may be separated after birth of the first twin. And in instances of malpresentation or vasa previa may result in long-term morbidity and mortality. So, if we have twins, of course, the complications more with the second twin. The second twin suffer more from the first twin. Why? Because the placenta may be separated after delivery of the first twin. This is number one. Secondly, the cervix of the uterus start to be contracted after birth of the first twin. Thirdly, the second twin may divide by rapid passage through the birth canal. So the second twin more exposed to the birth trauma, more to the birth trauma. So for these, second twin may suffer from the first one. Management. Of course, identify multiple gestation as early as possible. Manage any other medical problems. Controlling the birth labor. Identify the ideal route of delivery. Avoiding asphyxia in the second twin. Asphyxia, of course, we consider it as a disaster condition for the newborn, because asphyxia means you get a crippled, disabled new human being. So all your action in different conditions or different types of labor to prevent the infant from asphyxia. Asphyxia should be avoided. When you expect asphyxia, when any born, mature or premature, delivered without effective spontaneous breathing after complete delivery. If this not happen, my patient may expose to asphyxia. So keep this in your mind. Here we speak shortly about the maternal disease that may affect the newborn. Here we talk about the medical problem of the mother before getting pregnant. Maternal or maternal chronic maternal disease affecting the newborn. Of course, many women not free from other medical problem, but this problem not prevent such women to be pregnant. But if this woman get pregnant, what are the most medical that may affect her baby? First, idiopathic thrombocytopenia. Of course, as you know, antibodies are directed against platelets that cross the placenta and cause thrombocytopenia in the fetus and the newborn. As you know, we have antibody that attack the platelets in the same person. So if this woman with such problem, these antibodies will cross the placenta and consider the platelets of the fetus as a foreign body. And so these antibodies will attack the platelet. So this possibility increases the risk of intracranial hemorrhage. So close maternal and fetal management is vital. Infant with hemorrhage may need platelet transfusion or intravenous immunoglobulin. The condition usually resolves within few weeks. So your job here to prevent immediate hemorrhage or damaging to the sensitive vital organs like brain and lung. So easy to treat if you're aware about this problem. So important for you to take a detailed medical history from the pregnant women or even after delivery. Other condition or medical problem may affect the newborn. Immune abnormalities in SLE can lead to the production of antibodies that can cross the placenta and injure fetal tissues. And the most serious problem in the fetus is damaging to the cardiac conducting system, which results in congenital heart block. So we have neonatal lupus that may occur and is characterized by skin lesion, thrombocytopenia, autoimmune hemolysis, and hepatic involvement. The mortality rate is about 20%, and most surviving infants require pacing. So here, the effect of the SLE on the newborn is a permanent, not like or from the cytopenia. Thrombocytopenic newborn, if past the acute phase, they live normally without sequelae. But systemic lupus can cause a permanent sequelae. Neonatal hyperthyroidism is due to the transplacental passage of thyroid-stimulating antibodies. Hyperthyroidism can appear rapidly within 20 to 48 hours. Symptoms may include intrauterine growth retardation, prematurity, goiter, stenic, craniosynostosis, immature fusion of the sutures of the skull, flushing, congestive heart failure, tachycardia, arrhythmia, hypertension, hypoglycemia, thrombocytopenia, and even hepatosplenomegaly. Treatments include propylthiouracil, iodine drop, and propranolol. This condition usually resolve in a few months after, of course, treatment. So if you treat early, we have a good prognosis and the effect never to be continuous as a permanent condition with a newborn. As you know, any thyroid problem affects female more than male. But in case of neonatal hyperthyroidism, both newborn male or female affected equally because they receive antibodies from the mother, and these antibodies, of course, transient. So neonatal hyperthyroidism, keep in mind, affect both sex equally. Antiphospholipid syndrome, important condition, in fact, that result in a lot of complications. Of course, associated with thrombophilia and recurrent pregnancy loss. Considered important cause of recurrent abortion. Antiphospholipid antibodies are found in about 2 to 5% of the general healthy populations. Obstetrical problem and complication arise from the thrombotic effect of the antiphospholipid antibodies on the placental functions. So vasculopathy, function, and thrombosis have been identified in the mothers with antiphospholipid syndrome that manifested by fetal growth impairment, placental insufficiency, maternal preeclampsia, and premature birth. So these women should be examined clearly and diagnosed to prevent such problem and give the appropriate treatment in form of heparin in different doses. Other important maternal disease that we talk about this next in detail is diabetes mellitus. Up to this point, we finish our lecture. Thank you for all, and we receive your questions in classroom. If you have any question, we are ready for such questions. Thank you for all.